introduction, if we could go around, I'll state the entity and either the health department or others. We're really happy to be joined today by the CDC Data to Care team as well. So if you could please state your name and role within your organization, that's great. So let's start with the health department, and we'll start with the Colorado Health Department.
This is Jennifer Donnelly, and I'm in the room with a few others. To present with Maria Chaides, who are Data to Care, Linkage to Care Group, HIV Prevention.
Great. And you survey represented as well, Jennifer?
Not, but this coincided and kind of overlapped slightly with our division meeting, so they should be here shortly.
Great. Okay, thank you. And from the Virginia Health Department.
Brian Collins, can you guys hear me?
Great. Clear, thanks.
And this is Beth Sofowicz. I'm also with the Health Department, the Virginia Department.
Beth, could you just describe what your roles are briefly, or your positions?
Sure, the campus coordinator for Virginia.
Great.
The Prevention Information Coordinator.
Great, thanks. Okay, the Health Department.
Eric Jalone, and I'm the Surveillance Coordinator.
Hi, Eric.
This is Monitha, Linkage to Care Program Coordinator and the point of contact for the Data to Care with JSI. And in the room with me, I have Tony Price, who's the Program Manager, Keisha Hightower, who's our Contracts Monitor, and Jennifer Turner, Evaluator.
Thanks, Monitha, Eric. Other health departments who may have joined the webinar, could they please introduce themselves?
This is Betsy from Massachusetts. This is an STD Surveillance Director, and I'm here with Christian Haig, who's the HIV Surveillance Supervisor.
Great. Thank you for joining, Christian.
Greg in Florida, HIV/AIDS Surveillance Coordinator.
Thank you. Did anyone else want to introduce themselves who may have joined after we start, and then we'll move to CDC?
I'm Ann Rhodes from Virginia. I'm the HIV Surveillance Director.
Thanks, Ann. Okay, CDC team.
Jane Green. I'm a behavioral scientist and one of the co-leads of the Data to Care work group.
I'm a medical officer, and I'm one of the co-leads of the Data to Care activity.
Great. Looks like somebody's phone might be ringing or a call line. And my team, just really briefly.
This is Jeremy Holman, the project director.
Jean Day, one of the technical specialists working with Colorado and Maine.
Hi, Powers. I'm a TA specialist working with Hawaii and Florida, and I'm in our Atlanta office.
I'm a TA specialist working with Virginia, South Carolina. I'm in the Boston office.
I'm a TA advisor on the project.
And this is and I am the project support for the Data to Care project.
Great. We'll turn it over to you even a moment. Just a quick summary of our plan today. We'll have about a 25-minute presentation from Eve. Some of you may have received slides. If not, we'll be sending those to the others of you for reference. Followed by a Q&A discussion. Please hold your questions until that time. And again, if you could mute your lines until that time, that would be really great for the quality of the recording. Before I turn it over to Eve, any general questions before we get started? Okay, for joining. Really looking forward to an informative webinar and a very lively discussion afterwards. And Eve, we'll turn it over to you now.
Thank you. Afternoon or morning for those of you out west. Today I have the pleasure of presenting considerations for data sharing agreements for your health department Data to Care program. I thought that slide was just a minute. There we go. Objectives are understand the decision process for personally identifiable information on persons living with HIV outside of the health department, providing principles for data collection, storage, sharing, and use to ensure security and confidentiality, and understand how to apply them to the decision-making process. 3, identify and discuss the essential elements to include in a data sharing agreement. We've included a slide at the end with references and URLs so you can look in more detail at any of the documents that I will be referencing today. With some acronyms and definitions. MOA are Memos of Understanding and Memos of Agreement. DSA, Data Use and Data Sharing Agreement. C, Security and Confidentiality. The CARE, or DTC, is the abbreviation I'm going to use today to mean data to care, which is an overarching term for using surveillance data to identify, locate, link, and or engage persons already diagnosed with HIV in adequate medical care. Linkage is being done based on, for example, finding a person living with HIV previously diagnosed by a provider whose identity is not based on surveillance data that is similar to but outside of the scope of data care. Or AIDS service organization or community-based organizations. USO provides direct services to clients, while a CBO may or may not provide services. Since they mean different things to different people, for simplicity today, I use the term SO during presentation to mean either an ASO or a CBO. Data often means aggregate information, for example, a table where one is concerned about small cell size, potentially identifying an individual. But for data care, we mean individual level identifiable information, as in the next slide. To the acronyms, but perhaps most importantly, is personally identifiable information, or PII. It is defined as data that can be used to identify, locate, or contact individuals or establishments, or reveal characteristics or other details about them, and other information that is linked or linkable to an individual. There are both direct and indirect identifiers. Direct identifiers include name, social security number, or information that is unique to an individual. Indirect identifiers include uncommon race, ethnicity, extreme age, unusual occupation, and other details, a combination with each other or other information. I refer you to the S&C guidelines, which are at the bottom of the slide and listed on the reference slide at the end for more examples of PII. I'll be answering in today's webinar. Data sharing defined and used in HIV prevention and care. Why data sharing? What questions are health department asked to prepare to share data? Who are partners and considerations for sharing? What data should we use and how do we share the data? Involved with data sharing. What are the essential elements in a DSA, and what DSAs are available, and what sources should we reference for this process? With sharing is defined and used in HIV surveillance prevention care. Data is defined as allowing minimum access to PII to public health staff or agencies outside of the surveillance unit for specific public health purposes. More on this definition can be found in the source document at the bottom of the slide. The bullet are several reasons for data sharing: partner or contact management, assessment of parallel epidemics or syndemics such as TB, hepatitis, and STIs, assurance, limited research purposes, and engagement with care and treatment assurance. While it is most relevant for data to care, I think it's important to include all these reasons for data sharing because it puts data to care activities in the context of other reasons we share data in HIV surveillance, prevention, and care. Engaged care and treatment is relevant to data to care because we engage persons living with HIV into care and treatment. We need name, locating, and other identifying information. Agreement is defined in the 2011 S&C guidelines as a mechanism by which a data requester and data provider can define terms of data access that can be granted to requesters. Today, we'll use the term DSA broadly and go over types of DSAs and the essential elements to be included. With the decision-making process, which itself starts with the 10 guiding principles for data collection, storage, sharing, and use to ensure security and confidentiality. Moving on to these principles that underlie data sharing, I'm referencing the article by Lee and Gostin, Ethical Collection, Storage, and Use of Public Health Data, a proposal for national privacy protection, because the basis for the 10 underlying principles contained in the 2011 SNC guidelines, and this quote, by saying, despite its critical importance, there is no national standard for safeguarding data held by public health agencies. Instead, privacy safeguards are fragmented across 50 states, creating uncertain and inconsistent privacy protection. I include this quote because I think it helps us see that we're charting new waters here and explains in part why something so basic to public health work has been so confusing. Technical assistance CDC is providing via the 2011 SNC guidelines, last year's webinars on the topic, which I will describe more later on, the CARE tools on effectiveinterventions.org, the capacity building assistance programs, and other efforts will coalesce into more cohesive standards using the basic principles from this article and listed on the next few slides. That said, while CDC, GSI, and others can provide information and support, some decisions must be made at the state and local levels based on local laws and regulations while conferring with legal counsel. In this case, data sharing should be a careful and thoughtful decision and process. Slides contain the 10 guiding principles I just referenced previously. I reference them quickly as you go through the data sharing process. There are, number one, public data should be acquired, used, disclosed, and stored for legitimate public health purposes. Folks should collect a minimum amount of personally identifiable information necessary to conduct public health activities. Number three, programs should have strong policies to protect the privacy and security of personally identifiable data. Number four, data collection and use policies should reflect respect for the rights of individuals and groups and minimize undue burden. Number four, programs should have policies and procedures to ensure quality of any data they collect or use. Programs have the obligation to use and disseminate summary data to relevant stakeholders in a timely manner. Number 7 has direct relevance to data care. Should share data for legitimate public health purposes and may establish data use agreements to facilitate sharing in a timely manner. For more question on what is a legitimate public health purpose, I refer you to Standard 2.1 in the 2011 SNC guidelines. Briefly stated, however, a legitimate public health purpose includes efforts to prevent disease or premature death or health among members of a community through activities, several examples of which are in the guidelines. Programs may interpret this differently. Continuing on with number 8, public data should be maintained in a secure environment and through secure methods. The number of persons and entities granted access to identifiable data. 10, program officials should be active, responsible stewards of public health data. Once 10 guiding principles, these questions to prepare for your data to care activities. In conduct data to care, will there need to share personally identifiable information from surveillance? We need to share surveillance PII. What data elements will we need to share? We share it with. I will come back to this topic in more detail. Data. Do law regulations prohibit or limit this sharing? What is the experience handling confidential HIV data of the parties who will be accessing HIV surveillance data? And do they meet the 2011 SNC guidelines? Slides address the questions: who are my sharing partners and what are some considerations for sharing? Sharing, that is within the health department, but across bureau, divisions, centers, etc., is guided by public health need. This guiding principle numero uno, and compliance on the part of all parties with the 2011 S&C guidelines. The State and Council of State and Territorial Epidemiologists held 5 S&C training webinars last year. Technical assistance for them is available by viewing the 2013 webinars and tools and examples found in the webinar library at cste.org. Sharing usually uses less formal agreements than sharing externally, that is outside of the health department. But agreements on paper, regardless of what it is called, even for internal sharing, is a great way to make it clear what can and cannot be done with the data. It's important because HIV surveillance usually has a different idea of how to handle the data. Stated in this slide, all parties should be trained in the S&C guidelines before sharing occurs. Reinforces those guidelines and the training and helps mold the culture of all parties so they're in compliance. Sharing, back to my last bullet here, that is outside of the health department is more challenging and is the focus of today's webinar. Who are partners I will share with? You can validate data care partners, and primary examples include healthcare providers that are acting on behalf of the health department. They have been given, quote, public health authority. On the two slides, I will focus on ASOs because sharing with them is a newer idea with more complex security and confidentiality issues. Data care partner is defined as one that is acting on behalf of the health department that has been given public health authority, contract, data sharing agreement, or other legally binding document. Usually such an agency diagnoses and or treats HIV infection and has a relationship with the health department. But just being, for example, a health department-funded testing agency isn't sufficient to share surveillance data. You want to know the details in a legally binding document that could include, for example, the name of specifics who have access to the data, what will be shared, and should include what they can and can't do with the PI being shared. You may have liability issues for violation of the agreement. We'll do this when I discuss the essential elements of a data sharing agreement. This is a review of considerations for sharing surveillance data with ASOs that do not already have the patient's name. The type of sharing with ASOs for data to care is dependent on establishing their authority to act as an agent of the health department. It should be done with careful consideration and planning. From the person living with HIV is probably not required since the ASO will be given public health authority, but it could be beneficial and should be considered. Limited. If there is a data sharing agreement of some kind is required, initial and ongoing S&C training will be integral to successful sharing, which I will discuss in more detail later. It may potentially be helpful, and there are no clear examples to draw on. What are conditions for sharing new information on specific cases? Information on a person living with HIV is going from an external agency to the health department. Sharing agreement is needed between the health department and the external agency. From an external agency to a health department for a public health purpose is exempt from HIPAA and can be done without a DSA. If he insists on a DSA for the sharing, it must spell clearly that the DSA covers the information being shared for data to care only and states explicitly that the DSA does not cover information shared to report a case of HIV infection to the health department. It starts us down the proverbial slippery slope of needing a DSA for an agency to report a communicable disease, something that could inhibit reporting and is not part of standard reporting practice. The bullet covers when new information on is going from the health department to the external agency, and the DSA is needed. If the name originated from the health department and are going from the health department to an external agency and being re-released, such as a provider network, I recommend you consider DSA among all 3 agencies. I will example of this type of essay at the end of the presentation for New York State Immunization Registry, and is for groups of organizations who plan to share PII. Now we'll do types of DSAs and how to actually share the data itself. The terms and title of this slide seems to vary by organization. Some meanings for health departments include MO statement of principle, that is, an understanding. A would specify services and or what is being shared. A DSA could include or be an attachment to MOUs or MOAs, or used generally to describe any document that is used as the basis of sharing PII with an agency external to the health department. There seems to be a lot of variety in what these terms mean and when they're used. One department I spoke with used MOUs only for sharing specimens for incident surveillance. Even that a DSA is for agencies external to the health department varies. Another department I talked with used them for sharing across organizational boundaries within the health department. Health departments do not use formal DSAs internally, but it's a good idea to put terms of data sharing into writing, even internally. A good place to start is to look within the health department for other models of data sharing and agreements. This makes you a good sense of what the norm is for your jurisdiction. MOA, DUA, what should we use? The tip here is not to get hung up on what it's called. Which template to use will be determined by the legal counsel of the organization providing the data, that is the PII. The organization providing the data is usually the health department, but secondary release could specify another agency. What I call secondary release is if the health department shares data with an external agency, for example, ASO, and that ASO wants to share it with others, for example, providers. If so, the original DSA should either specifically allow or disallow secondary release, and if the terms of such release should be spelled out. This needs to be a deliberate process with thorough discussion between organizations about why and how PI is to be shared. What's important is that the essential elements to be contained in whatever agreement you write. However, legal counsel may add or subtract from the essential elements I'll be going over. Determine that you will be sharing the data. How may PII be shared? Data shared using secure electronic methods, for example, using an encrypted file or SFTP. In accordance with S&C guidelines standard number 5.0, over the phone is an option, as is direct contact with surveillance units. Second and third bullets, health departments should be guided by how they use these methods of sharing information during routine case reporting activities. PII data not to be shared. Use should be discouraged. It is harder to control access and too easy to leave somewhere. Next, email, even in the health department, standard 5.3 in the 2011 S&C guidelines. Even the standard says emailing unencrypted PII is not allowed, implying encrypted is allowed. Of email can be subject to Freedom of Information Act, FOIs, which implies that the health department may need to unencrypt it to respond to such a request. The rule of thumb for sending any email, but especially email to, from, or within a government organization. For send, picture the content in letters 3 feet tall on a billboard on the highway. I actually find this quite helpful. Does this look okay? You can hit send. If it's okay, don't send it. What governs confidentiality of data sharing? Laws and regulations related to bidirectional sharing or individual level HIV case surveillance data, and internal and external agency compliance by the providing and receiving agencies with the S&C guidelines from CDC. Data sharing work starts and ends with legal counsel review. You should understand requirements of state reporting and rules and regulations. Will determine the need for an MOU, MOA, or DSA. I can include a DUA. This will probably not be needed for linkage to care activities, but it's better to have at least discussed it beforehand. 20 S&C guidelines. The The subtitle of this document is Standards to Facilitate Sharing and Use of Surveillance Data for Public Health Action. The principal value understanding of the standards listed in these guidelines is that both the health department and any organization with whom a health department shares PII must comply with them. Remember the minimums I emphasized when I was reviewing the 10 principles earlier. Minimum data elements shared and stored, and minimize the number of people who have access to the PII. This means the department's first step in developing a data to care program is complete the S&C guidelines. CE produced a series of webinars last year on how to comply and included one specifically on data sharing on July 25th, 2013. It includes presentations from New York City and Louisiana, and the reference and link to it is included in the reference slide below. Security is our highest priority. Even if a formal agreement has been executed, S&C guideline training should be done upon hire with all new employees and annually. Training is an ongoing process and can involve changing the culture of a program or agency. The content should reference stipulations in either informal or formal data sharing agreements about what can and cannot be done with the data being shared. That way, the team reinforces what's in the agreement. S&C is an ongoing process, and the policies and procedures should model a culture of maintaining the highest level of confidentiality for PII. The health department can assist external agencies with practices to promote this. For example, placement of confidential fax machines and copiers. Person which works well done periodically, or for example, staff can sign off after reviewing a series of slides or a policy. There's an example of this from Kentucky Public Health in August 26, 2013 webinar in the CST webinar library. I will close by reviewing the essential elements of data sharing agreements. Determination is made that a data sharing agreement is needed. The following elements should be included: identification of the parties providing the data, receiving data, and all of those who have access. Purpose of the agreement: what public health goal is being met, including under which sharing is being done for both parties. Rules may be different for the two parties. For example, does HIPAA apply to the health department or the external agency? Roles and responsibilities of all persons with access to the data, and a description of staff training and confidentiality certifications, and specify adherence to the guidelines. Data to be shared, such as specific data elements and data formats. In this area, clear, unambiguous language is especially critical. It should include allowable and unallowable uses, and including any unallowable uses that are of particular concern. Including information being shared can be redisclosed by the receiving party. Ownership. Does the health department retain ownership? It's most important when the applicable laws of the health department persist in governing the uses and disclosure of the data, regardless of who holds the data. Data will be shared, that is, how often and how transmitted. This is my slide on essential elements. The date range should also be included, that the date range data that are shared are the date range data that are the sharing agreement is in force, and the termination date, including procedures for rescinding the agreement. Specific and electronic data security procedures, procedures to destroy or remove access to data at the termination of the DSA agreement, prior amendments and/or addendums, notice of breach or misuse of data, for non-compliance or violation of agreement terms, and lastly, signatures of the certifying officials. What do we do now? Well, the data, monitor compliance, ensure ongoing S&C training, amend DSA as needed, renew the DSA or close it out. Frequency of that for renewal will likely be determined by legal counsel, but annually would be a good frequency to consider. It includes a list of sample DSAs in no particular order, and to maximize our discussion time, I'm not going to review them right now. Jay is providing the slides and sample DSAs to you for your review. So references for you to use when doing this work. I will show you two that I think will be primary references for you. These are the 7 cross-program integrated S&C guidelines from CDC. They represent the first time CDC produced guidelines across all of the divisions in the Center for HIV, Hepatitis, STD, and TB Prevention, and this on which data sharing is done both within and outside of the health department. You should familiarize yourself with this document, and the health department should review their own compliance with it before considering data sharing within or outside of the health department. This is the Interjurisdictional Health Information Exchange Guidance for Public Health Agencies, published in September of last year by the Joint Public Health Informatics Task Force. I made a picture of it here because you may not have seen it before. It is practical and I think can help guide your work. It's geared to health departments from neighboring states sharing data with each other. For example, sharing information in immunization registries. As much information relevant to the kind of sharing involved with data to care. Up for discussion, I want to close by thanking Luke Schaus, Pat Sweeney, and Mark Stenger from CDC and the JSI staff and TA providers for their helpful input and comments. You want to take it out, or Michelle, for question discussion?
Yeah, great. Thank you much, Eve. We're going to open it up to any questions or discussion. We really see this as an opportunity for cross-health department learning. And we have Eve as well as CDC resources and the JSI TA specialists on the line, but we're really happy to have Eve here to provide some facilitated discussion and provide some consultation. So if you can open up your line and ask your question, please state your health department and again your name and role within the health department. That will help.
Questions I know that specifically Colorado and Virginia had, and in order to keep this to a half hour, I had to not necessarily every single thing you asked about. So please do bring up this is the time for this. Bring up questions you might have had that I didn't address. Just anything that's come up for you around this whole issue of how the heck to share data in a confidential way, because we are leaders here, and I think we can learn a lot from talking to each other. There are questions that I'm sure I didn't touch on that you had that you wanted to get answered.
Eve, this is Eve Rhodes from Virginia. I'm the surveillance coordinator. So one of the things that we've, and our prevention and care people couldn't be here because they've already got a couple of their meetings today. So I'm sort of speaking for the coordinator here. Just want to, issues we've been sort of struggling with a little bit, I think, as we've talked through this is, so we've got our loss to care list that we've did from care and surveillance data together, and then, we sort of have limited to go more people. We're funding a lot of patient navigation throughout the state, so we'd really like to be able to use patients, I think, and to do loss to care work. Trying to determine is, can we give the loss to care list to patient navigators at these different sites? Some of them are medical sites, some of them are CVOs. And so I think that's where, I think the information you presented is useful as far as sharing. I think we're still just trying to figure out, is there any sort of, what you share with them as far as, all of our HIV cases, because, all of them, all HIV cases that we know have fallen out of care, and so is there any kind of limit on what we share for people to go outside to find people?
Where did you work you said CBOs and where else? I kind of missed that.
So medical data scientists.
Uh-huh. I think some of the things I touched on really help, and I think I have to thank Pat Sweeney for suggesting I put circles around the words minimize and minimum in the 10 guiding principles, and I think that partly answers this question. I mean, you want to ask yourself, what's the minimum amount of information I need to give them? I would not open up your HIV registry for them to be able to look up anybody they want. I'm not saying you're suggesting that, but that would be the other end of the extreme, completely unnecessary. I know you were suggesting that, but it's a good extreme to think about on the other end. If you developed a not in care list and they have particular made a decision about why some of them would be best to follow up on particular types of patients, I think you have to do all the training with their organizations. If they work for lots of different organizations, that's going to be more challenging, I think. The training that you'll have to do with the different agencies that you would have to have a data sharing agreement with and do it. I would also suggest, if you haven't tested out your not in care list, you're probably aware that a lot of people found, when people start doing this work, they discover things like, oh, these patients a lot of them have moved, or oops, that time we forgot to do the death match, some of them have died. So whatever you do, I would start with a few and see what happens. I wouldn't. So, and I think just keep thinking about the 10 guiding principles, the whole issue of minimum, and you'll have to go through the process with the different organizations they work with, so that they are in adherence with the guidelines. Does that help you?
Yeah, I think that's what we're trying to figure out is what is what kind of the minimum pieces we're due. We are trying to start small. We're putting up small with DIS right now, and that's just starting, so we can figure out, because this is what we've heard is, a lot of our other states are from people on these not who are actually in care. So we want to see what we actually find as we generate these lists and what the issues are before we would expand it out to a wide audience. And we just procured Accurate and LexisNexis, so we're hoping to be able to start using that a little bit to or at least figure out some people who might be out of state.
I mean, a classic situation, like you, Maryland, and D.C. have this classic situation of a metropolitan area that spans jurisdictions. And so, I mean, I'm sure you deal with that all the time with people going out of your jurisdictions with Maryland and D.C. on that side of your state anyway. So, yeah, I think that's the approach to take, but I do think you have to figure out how you're going to do the training that needs to take place before you can even share a small number of elements on a small number of people.
So too, and the thing on the interjurisdictional health information exchange will be useful, because we've actually been working to set up a data sharing agreement with DC, which has been a little bit stuck in on both sides, I think, for a little bit, but
yeah,
I'll look through that.
Great, good.
Thanks.
Sure.
I'm Giovanni. I'm the Care and Treatment Manager in the state of Colorado. Hello, everybody. So there's questions that we've been wrestling with. I know a lot of this is actually governed by state law, so we don't expect you to be an expert on our state law. But I'm trying to get around this whole idea of secondary sharing. So let me paint a scenario, and you tell me whether we have well, you're going to have a thunderstorm soon, I see.
I closed Weather Channel app, so you
I usually say tornado warning.
Depending on where my friends and family are at the moment, that's what city gets added to my list. I did close it, but I see it didn't prevent that. Okay, go ahead. I'm sorry.
That's all right.
Scary. You know what? I'm going to go back to that slide while you're talking.
Okay. So let's do a scenario, all right? So we have a local, so in Colorado, our state health department is a legally separate entity from our local health department. I know that's not true everywhere, but they're complete separate legal entities. Come at the same under state law, but with some restrictions. We fund one of those local health departments to do linkage care for people in their jurisdiction. That local health department, people that we believe are, jurisdiction are not linked to care. They take that list and they see, 6 of these clients are eligible for Medicaid and 2 of them are eligible for Marketplace plans. When they meet them, they say, here's the possible providers you might want to do. We can help you enroll and get that all set up. And then off that long list picks Dr. Jones, because we told our local health department partner that this client was HIV positive, that our state health department has to have a data sharing agreement with Dr. Jones.
To Dr. Jones, the patient is taking themselves to Dr. Jones, so you don't
Correct.
need a data sharing with Dr. Jones because the patient is revealing their own status by going to the
That's what I was
doctor.
hoping you were going to say. But
it
no. Originate with a public health record, so that local health department would never have known that person was positive and never would have known to refer them to Dr. Jones if it hadn't been for the data sharing at the beginning.
Right.
They didn't reveal, let me give a second example. We give them the most recent viral load for that client, right, which is 3 years old or something. And then our local health department partner says, Dr. Jones, we're sending a patient over there. Here's their last known viral load score.
Well, and I think if the patient is following the information,
volunteer that information. So we took that out of their public health record. Report. So we not only, let's just say and we're not doing this right now, but let's say we not told our local health department partner, we haven't seen any evidence of care for a year, and here's their most recent viral load score from their public health record. The department partner found out the client wants to go see Dr. Jones, and prepared Jones for that visit, said, we sent that patient over to you. We all happen to know that patient's most recent viral load score, and here it is.
This is a situation where having the patient sign off on you sharing that information could be helpful. Luke, do you jump in here?
It's Luke Schaus from CDC. I think Eve is exactly right here, that once public health has gone out, contacted the patient is agreeing to then enroll in care with Dr. Jones. I think it's okay to share that information with Dr. Jones at that point, because the patient has given their consent for you to set up their care with Dr. Jones. I think that, having some kind of formal process where you say, we would like to share the data that we have on you with Dr. Jones, which will, help facilitate your care with him, and having them either verbally agree to that and you document that, or having them sign, something that says that it's fine for you to share that information with Dr. Jones. It's even more important if it's time they're going to see Dr. Jones. If you're engaging them in care with Dr. Jones, I don't think that's so important, because it's clear that they already have a relationship with that provider, and that provider should already have a lot of their personal identifying information already. But I think if you are setting that up, I think it would be prudent for the health department to make the patient aware of that and somehow document it, whether it's in, made the patient aware they gave us verbal consent and the DIS or whoever's doing the contact notes that, or you actually have them sign off on some kind of form that says, that as part of helping facilitate this linkage to care, that you're going to share the information you have on them with Dr. Jones.
For us. We've traditionally said that even the clients themselves can't consent to the release of their public health record, right? So we're kind of moving to this new way of looking at the world.
Yeah, and maybe these are big changes for health departments. They're changes for the way departments interacted with providers, and it's a big change for how we've interacted with HIV positive clients in many areas. So, Eve mentioned earlier with Virginia, which is start small. So maybe you start off by not doing anything other than linking the patient to care, helping them with an appointment, getting them enrolled into that, and facilitating that linkage, and then move after that's working for you, maybe you move to sharing, say, just simple contact type of information and that kind of thing. And then if that's working for you and things are going well, then maybe you move and share a little bit more. I mean, these are big changes, and I think you need to find kind of that the place the health department, when I say you, I mean the health department feels comfortable in moving forward. So, taking everything you have on that patient and printing it out and giving it to the provider, there's nothing that says you need to do that.
No, and that probably wouldn't be even all that helpful. Even in the example I gave, I don't know why a 2-year-old viral load is particularly helpful to any doctor. Let me give you a second case scenario, and this one is actually something we are immediately wrestling with. It might again be a peculiarity of Colorado's laws, but nonetheless, the way we historically interpreted our law is that local health partners are entitled to public records having to do with people in their jurisdiction, right? So if it's a Denver County resident, we allow them access to the content of a public health record having to do with a Denver County resident. That's limited just to our local health department partners, right? So getting into linkage to care gets so interesting now, right? So we have a patient who was tested 10 years ago in Denver County, joined our AIDS drug assistance program, and the latest application they gave us shows that they no longer live in Denver County. They're not being linked to care properly, so we send some to talk to them, and we find out they moved to a third jurisdiction, right? They're on a couch in county. All of these counties is entitled to that public health record. Now it has a reason to be sort of linked with 3 different jurisdictions, and we're really wrestling with clients suddenly go, oh, I'm crossing a county line. I have kind of legal protection over my health information. Now it's all going to go to this new person I'm sleeping on the couch with for 2 days, right?
Let me tell you my perspective on that. And I'd be curious to hear Luke, but I want to jump in first before I let Luke respond. I think the answer to that question is yes, all 3 of them, and I'll tell you why. You have to think about where the responsibility lies for public action, and the local health department has the responsibility of protecting the health of the people in their jurisdiction. You can't possibly know at what point in time this person is in what local health department's jurisdiction. If there's a reason, if they've been in that jurisdiction or you think they're there now, there's a reason for it and you're mistaken and you find out it was supposed, they've moved to county Y. I don't think you can possibly keep track of that. I think that if you are released public health with purpose, getting back to our principles constantly, that you have a legal, it sounds like in Michigan we would have, I'm assuming you do as well, they had residents at some point in that county and you had reason to believe at the time you shared with that county that the person was residing there or the provider was there, that there was some public health purpose in that. I think that's okay. You don't want to overshare, but I really think that's okay. I'm curious what other people think, but that's my perspective.
Oh yeah, well that's certainly one of the positions that's been taken. Other people that are less comfortable with that.
So this is Luke, and I'll give my perspective. And I guess first and foremost, I should say I think this is a great example in our president. Eve pointed out that a lot of these decisions, shared a lot of principles and a lot of questions and things to consider. But when it boils to it, a lot of these questions do have to be answered at the state and or local level. And I think this is a perfect example of that. And in my experience working with surveillance programs across the country, this has been decided different ways. So some health jurisdictions have decided that it's only jurisdiction where the person currently resides, and that's using the best information that you have on their last known residence. That's the only jurisdiction that has the right to see that information currently. So like California is an example of where they have allowed like their surveillance record, if the person has lived in or ever received care in a jurisdiction, then that jurisdiction has the right to see if either all or part of the record, depending on what happened in what that person did in that jurisdiction, whether they reside or whether they just received care there. Kind of split it up, and so some people can see the entire record. Other jurisdictions can only see the part of the record that applies directly to the care that they've received in their jurisdiction. So they've they've done a mix of that. And other jurisdictions that are just like, the person's lived in your jurisdiction, you provided them care, and you have a right to see the record of that individual, which is kind of what I think Eve was suggesting. And I think there are examples across the country of all three of those models, and I think what it boils down to is what does Colorado law require? What is its, does it limit it or does it leave it open? If it's open, who gets to determine? Is it the health department who gets to make the decision, who gets to see it? And so then I think it gets up to the health department to ask those tough questions and then come up with what you feel is the best approach, which would have the public health outcome.
And kind of ask yourself those questions and those guiding principles. Why am I sharing it? What's the minimum amount of information I have to share to reach the goal or the outcome I'm looking for, et cetera?
The person was diagnosed 10 years ago in K. They haven't lived there since. They're living in a county all the way across the state now. Does County A really have a vested public health interest here to see that data if they're not going to be providing care or not be the entity who could go out and offer linkage services to them? So for data care, even though they were diagnosed there, it's been enough, the person's not lived there in a long time, that there's really not a public health purpose for them to really have access to that data at this point.
And care that's brought this to the surface, because historically it's exactly how we've interpreted it.
Yeah.
No matter how long ago it was, one case always a different case, right? And
yeah.
Always a different case. And that, now data care is like, well, once we're doing now that we're having a different purpose for this data, that doesn't make much sense anymore. And I'm not sure, frankly, I'm not a surveillance person, never have been a surveillance person, but I'm not sure how helpful that was, period. Even back when, it's like, it's just to see all of that thinking this county has a big burden of disease, when in fact, all that was where they were tested 10 years ago, and they happen to have the best STD clinic out there, or they just happen to test a lot of people during that time, but there's no sense that that's an accurate description of the disease burden of that county. So getting new updated addresses is a big priority here now.
Almost an artifact, and I'll throw this in because you stated explicitly your background wasn't surveillance. This artifact from the fact that for 30 years, residents at diagnosis, how they've assigned morbidity in surveillance, and we're still struggling because we can't follow people every go. With being able to switch to current residents, because residents at diagnosis may have meant something in 1989. It means very little now. That's the remnant of, Denver, where they're diagnosed, so Denver always gets to know. So you have to shift as we're struggling with trying to, most current residents or whatever you want to call it. It's an artifact of the ancient surveillance. Morbidity's been assigned.
Chances the person was not going to be living much longer. So
exactly.
It was really a 2-year time frame here, and they probably weren't going to be moving around a lot. But now we have, thankfully, people living decades now, and I certainly don't live in the same county I lived 20 years ago. So what effect our clients are.
So, this is Luke again, and I just wanted to take an opportunity to jump in because there's the question about, which I think Eve answered perfectly, about the data re-release. And in her slide presentation, she talked about if surveillance with one agency, and then that agency is going to re-release it, that they consider a data agreement that encompassed all three agencies. And although the question number had, I think Eve answered exactly correct, that's probably not necessary in that situation because the client's giving their consent to be linked to that provider and to that data. What we were thinking about there is an example that some people have brought up to us, where some ASOs or CBOs have been in conversations with medical care providers to offer them linkage services for their clients. And so what that would be is a medical clinic would contract with an ASO that when their patients fill out of care, that the ASO would actually be the people calling for that healthcare provider and then going out and trying to get that person relinked to care. An example of a situation where we thought, well, if the the health department data to that healthcare provider and said, hey, we see this patient that you used to have, they're no longer linked to care, and if you have linkage services, would you get them linked back into care? The healthcare provider says, sure, I contract with the SO down the street to do that activity. Then healthcare provider would then be turning around and re-releasing that information to the ASO. And that was an example of a situation where we thought that a case that was generated from a data to care activity looking at surveillance data and identifying someone as not linked to care would go to a healthcare provider, and that healthcare provider actually be releasing that data to someone who's not actually their employee but may be a part of the program they have for linkage. And so just to cover the ground and make sure everybody is understanding what's happening and who has access to data and everything like that, it would be good to consider a data sharing agreement that involved all three parties. An example of that.
I understand what you had in mind much better. Thank you.
Mm-hmm.
We have left. Any other questions? If don't hesitate to go to your JSI TA, and of course they'll contact me if need be, or if you want access to me afterwards, we can see if that can be arranged.
Thank you. I want to reiterate that this is Michelle from JSI, that please follow up with your JSI TA specialist if you would like any follow-up consultation with Eve related to the issues that were raised today, because this is such an important issue and new arena. So any final questions or comments before we close out? Okay. I do want to say that the TA specialist will be sending a link to evaluate this webinar, and we really look forward to your feedback so we can continue to provide quality technical assistance services in the future. So thank you for your feedback, and thank you all for your participation and comments and discussion today.
Thank you.
Thank you.